to discuss the role of pharmacokinetic guided approach to dosing 5-fluorouracil, really as a novel approach to deliver personalized medicine in the treatment of colorectal cancer. The current standard is to dose the vast majority of our cancer drugs using body surface area, BSA. And BSA dosing was originally developed back in the mid-1900s, and it was based on the study of only 9 patients. And really, the BSA formula was using height and weight to get an approximation of the total body surface area of an individual. And then over the subsequent years, it was used to try to approximate the dosing that was identified in preclinical in vivo animal model systems to then figure out kind of initial dosing in first-in-man phase 1 studies. And then in the 1960s, it was really kind of adopted then to be used as the method of dosing patients with chemotherapy drugs. So if you look at the history really of BSA dosing, there absolutely is no rigorous scientific basis for the use of BSA for administering cancer drugs. And it's interesting, over the last 15 to 20 years, there have been a number of commentaries in the Journal of Clinical Oncology, some of the European oncology journals, where I think it really has been questioned what the real value of BSA dosing is. So when BSA dosing was developed to administer cancer drugs, the thinking was that it could help to eliminate inter-individual variability. And as you see here in this slide that comes from a review paper by a group in Italy, that there is significant variability in drug clearance of a wide range of very commonly used cancer drugs that we use in everyday clinical practice. BSA dosing is really inaccurate for extremes of body size, body habitus. As we've already discussed, it does not account for the wide range of sources of pharmacokinetic variability. As I'll show you in a moment, there clearly is a lack of correlation between BSA dosing and drug clearance. The original intent of BSA dosing was to reduce pharmacokinetic variability, but actually it can only do so modestly and not in the vast majority of cases. As it relates to 5-fluorouracil, there in fact is up to 30 to 100-fold inter-patient variability. And we know actually that when BSA dosing is used, which it commonly is, certainly for 5-FU and most other standard anti-cancer agents, there's a very narrow therapeutic window. And if you go outside that narrow therapeutic window, that can lead to increased toxicity and ultimately to lack of clinical efficacy. Please feel free to email me directly. My email address is chue2, so that's chue2 @upmc.edu.